Welcome back to the Dermcast studios. It's Rob Casquejo for Dermcast TV. I have the honor today of interviewing Dr. John Barbieri, and welcome, Dr. Barbieri.
Thank you. It's a pleasure to be here.
Absolutely, and thanks for taking time to speak with us today. So you're a heavy hitter in acne rosacea, and you're lecturing here at the summer conference on those topics. A well-published dermatologist. You're an assistant professor at Harvard Medical. You're working at the Special Acne Therapeutics for Brigham and Women's Hospital. So very learned and great things to tell us, I'm sure, on the subject. So we're going to get into this and talk about probably all the practical things about acne rosacea management. So I'm going to sort of let you go, but I'm going to start by directing you this way. We have a compendium of medications for acne, and they seem to still keep coming even at this point. So give us your initial approach, classic acne patient of any age, although that can cause some differences. Where do you start? How do you go about it?
Yeah, this is a really important question. When we try to make these decisions, it's really important to engage in shared decision-making with the patient. So everything I'm going to say here is kind of a framework, a guide, but ultimately we're going to want to tailor things to the individual needs of our patients. When we think about acne, there's a few kinds of acne bumps we can get. We can have those whiteheads and blackheads, open and closed comedones, and then we get into the more inflammatory bumps like papules and pustules, and then the deeper nodules and cysts. And so depending on what kinds of lesions patients have, we might pick one over the other, and we'll kind of bring that in as we go into the treatments. And then when we think about treatments, they really fall into a couple of main classes. There's topical retinoids. Those are going to help address that hyperkeratination, that kind of clumping of skin in the follicles where they're getting clogged up. And they're a little bit anti-inflammatory as well. We've got benzoyl peroxide, which similarly is going to do some of those things and has some antibacterial properties. We've got topical antibiotics, right? If C. acnes, microbiome are playing a role in acne, just get rid of them. So topical antibiotics and oral antibiotics. And then we've got antiandrogens, and those can be topical, like clascoterone, or there's oral ones like birth control pills and spironolactone. And then finally, we could just get rid of the oil gland. That's the key player here. You've got hormones that come on in puberty. They turn that oil gland on. Everybody's acne is hormonal, whether you're a 14-year-old boy or a 35-year-old woman. All acne is fundamentally driven by hormones to some degree, and that turns on that oil gland. That's driving all these processes. So let's just take the oil gland out of the picture. That's really what something like Isotretinoin Accutane does. There's also a laser that's 1726 nanometers that specifically targets that oil gland. When we think about kind of how to use these, if you have someone who has more just comedones, just whiteheads and blackheads, topical retinoids and benzoyl peroxide are amazing at that. So that's usually the place to start. If someone's got some more inflammatory bumps, like some papules and pustules, bringing in addition, a topical antibiotic can be a nice way to go. And then for people with more severe acne, maybe we add in clascoterone on top of that, or maybe in someone who their acne is flaring with their menstrual cycle, or we think even though all acne is hormonal, there might be a more hormonal component for that person, we might use clascoterone. And then if their acne is more severe, then we're thinking about those systemic treatments, antibiotics, antiandrogens, and isotretinoin, and we can get into those a bit more in this discussion. So that's kind of the starting framework. And it's really about balancing the patient's severity, what kind of lesions they have. And then within those classes, I really just try and pick the least expensive or best covered treatment. There's very little evidence that any topical retinoid is better than another, that any topical antibiotic is better than another. There are some minor differences between them, but in my mind, not enough that it really directs my initial approach.
So what I'm hearing here is a lot of is a sort of treat what you see. The medicines sort of categorically have very specific targets, so you treat what you see. Is that fairly accurate?
I think that's right. Certainly they work on kind of all types of acne, but some of them are better for specific things than others. So I do think that's really important. And as we talk about rosacea, we're going to see it's even more important in that setting.
Right. So you mentioned things like oral medications. So once we get into these positions where we're using oral medications, it can be hazardous navigating this sometimes because we know we need a lot of time for it to work. So talk about the process of getting them through antibiotic therapy. Where do you start? When do you stop, et cetera?
Yeah. And I think this fits into this broader discussion of systemic treatments for acne. And what's hard is they're also different. In a lot of areas, kind of the systemic treatments are really using the same overall targets, and they might be a little bit less often, or they might be a little bit more effective than others, but they're very similar. The acne treatments are totally different. We've got oral antibiotics that are going to kill the acne bacteria. They might be a bit anti-inflammatory too, but they come at a cost of potentially injuring our good bacteria, our microbiome in our gut or on our skin, and they are known to cause side effects like GI distress, nausea, etc. yeast infections in women, and also some of them sensitivity to the light or other kinds of side effects. So that's a challenge with oral antibiotics. And unfortunately, most patients, although we want to try and minimize antibiotic therapy, because it's not a acne modifying treatment, because it doesn't make their acne less over time. If someone's going to have acne for 3 more years and you treat them with antibiotics for 3 months, when you stop, guess what? Their acne's back, and you're going on and off, on and off. Right. So they can be really challenging. And when I use them, I really tell people, like, this is going to be a long time probably if we do it, not necessarily going to be just a month or 2, even though that's our goal. It usually doesn't work that way when we look at the data. And then we've got antiandrogens, like combined oral contraceptives, spironolactone. Unfortunately, you can only use them in women with acne, so they can't help our male patients with acne. But they work really well. They're generally well tolerated. They don't cause a lot of side effects. They can cause, spironolactone can cause some lightheadedness, can cause some headaches, maybe going to the bathroom more often. But most of the time, there aren't major issues at the doses we use. But a challenge with those is they're slow. Antibiotics, people get better maybe in 4 to 8 weeks. You can really tell. Antiandrogens, it's like 4 to 5 months to really reach the maximum benefit. So if you want to get better for prom in 2 months, that might not be where you pick. Then isotretinoin, amazingly effective. It basically always works. It is disease modifying. It can make people's acne go into remission. 4 out of 5 people, they do a course of isotretinoin, and they don't need to do anything after, which is amazing. But it comes at a cost. It has a lot of side effects. It can cause dry skin or dry eyes, and that doesn't always get better when people stop. So that's an important consideration. It gets less, but sometimes it doesn't completely go away.
That's a great summary of really the broad view of systemic medications we have. So let's transition that to rosacea a little bit, because I would imagine it's a similar process. So again, let's start at ground level. Typical rosacea patient walks in. Where do you start? Where do you go?
The first thing is to talk with them about what bothers them about their rosacea, because there's 3 main kind of rosacea components. There's redness, so that could be background erythema, that could be flushing, that could be telangiectasias. There's bumps, just like in acne, papules and pustules. And then some patients, especially sometimes male patients, can get this thickening of the nose called phymatous changes. And depending on what bothers them, what we see, that determines how we treat. For redness, we're thinking about alpha agonists that are going to cause those blood vessels to squeeze down, like brimonidine or oxymetazoline. We might think about vascular lasers. For bumps, it's kind of like acne. We're going to pick antimicrobial things, so metronidazole, ivermectin. Now there's an encapsulated benzoyl peroxide that is well tolerated by patients with rosacea, unlike some of the issues we've had with more classical versions of benzoyl peroxide. And for phymatous changes, that's very hard to treat. We often have to use things like isotretinoin or oral antibiotics, which also are what we use for patients who have more severe papules and pustules as well.
Great. So let me ask you this question. Those are some of the mainstay treatments, again, of rosacea management. What are your feelings on the use of laser in rosacea?
I think it can be incredibly helpful for patients, especially who have like telangiectasias or fixed redness. It can cause durable improvement in that redness. The challenge is it can be expensive. It's just not accessible to all of our patients, which is unfortunate. There's a funny thing in dermatology where sometimes the physical bumps or things that cause symptoms get covered by insurance, but things that maybe don't have symptoms like redness, so flushing can sting and burn, don't get covered as well. So we see in rosacea, the treatments for redness are very poorly covered, whereas the treatments for bumps are relatively well covered. And I scratch my head going, why do we only care about one part of rosacea?
Right. It's a part of the same clinical picture, causes the same problems and the same psychosocial impact as well. So in terms of lasers then, what do you find to be more effective? PDL, YAG, filtered light?
Yeah, I tend to like pulse dye laser is probably my go-to choice for someone with rosacea. Usually the redness is sometimes less noticeable in patients with darker skin, but YAG you might think about someone who has darker skin or has other things where you want to treat someone's darker skin.
Right.
And beyond that, I don't tend to use a lot of other ones. I think KTP can work well. I think intense pulse light can sometimes work well, especially if they have some like poikiloderma, some dark spots as well, because it can get both. But pulse dye laser is usually my go-to.
Right. So there's a lot of overlap, right, between acne and rosacea treatments. We go after similar processes, although they're very different diseases, obviously. And you're for the American Academy of Dermatology, you're on their work group for acne treatment guidelines. So what's going on there? Is much changing, or where are you guys in terms of your work?
So we're in the process of developing the guidelines. It's been different than how it's been done in the past. Now it's done through this rigorous grade process where there's basically a systematic review of the literature and summary of all of the evidence for each treatment class that we're looking at. It's almost a bit like a Cochrane review in that way. It's very intense and rigorous in methodology. And then we have a whole work group and we meet and we discuss recommendations for different types of treatments together as a group. And then we formally put those together at the end and publish them. And right now, we're pretty close to being done and having things ready, but it's going to be another few months. So probably be early next year that the guidelines are formally released.
Great. So we'll look out for that. That's
Yeah.
something that we can look forward to in terms of our clinical management. So that's fantastic. So let's kind of end off here with some,
Okay.
I'm just going to bounce some things off you.
All right.
So just so I can pick your brain so our viewers can really sort of, benefit from your knowledge and your experience. I'll just a couple of questions and we'll see what you have to say about it. So you mentioned the systemic treatments for rosacea. So sub-antimicrobial dose doxycycline. Well, before I go into the rapid fire section, just talk about it as a therapeutic.
Sure. So both for acne and rosacea, we sometimes think about what I actually call low-dose antibiotics, and I'll talk about why I say that in a second, or get to why I believe that in a second. It absolutely can work. So for both rosacea and acne, lower dose regimens of antibiotics like 40 milligram extended release doxycycline or 20 milligrams, something like twice a day doxycycline, absolutely can work. The challenge with them is that I don't actually know if they're accomplishing our goal of trying to reduce impact on the microbiome or things along those lines. This idea that like if we use a low dose, that's safe and we don't have to think about it. Because when we look at that, there's two main assumptions. That doses that are lower don't impact the bacteria we care about, and that they don't lead to more resistance problems. And when we look at the data, it doesn't really support that. So first off, that we're actually doing low doses and that's good. So we talk about this idea of minimum inhibitory concentration, which is this like how much antibiotic does it take to kill a bacteria. And a lower number means that you need to less, and a higher number means more. So we want an antibiotic that has basically a low MIC for things like C. acnes and higher for everything else. That's like the goal of something like Tetracycline. In low-dose antibiotics, we're trying to stay below everything. But when you look at the data about it, really the MICs they talk about are just for a few bacteria, and every bacteria has different MICs.
Right.
And so we really have a lack of data that these low-dose antibiotics are actually below the MICs of other bacteria. Yeah. And in the gut especially, the concentrations are much higher before it gets distributed across your whole body.
Sure.
So it's very likely that these submicrobial doses, as some call them, are actually not submicrobial for many of the bacteria that are seeing them in the gut or on the skin. And that's why I prefer low dose to start. The other issue is like this idea that lower dose is good. You know, Alexander Fleming with penicillin was concerned that people might underdose themselves and that would create resistance because you give enough antibiotic that it's there, right? The bacteria see it, but not enough to kill them. And eventually they're going to be like, wow, I need to like respond to this. Even if it's not killing me, it's annoying.
Right.
And when you look in the lab, if you give bacteria sub-lethal doses of antibiotic, they develop more resistance, more mutations. Right. And in vivo, when we look at people, these low-dose antibiotic regimens still cause resistance. You still get staph and strep resistance to doxycycline. You still see changes to oral flora and other microbiome. So right now, really just the data doesn't support that these lower-dose regimens are fine. Okay. They certainly have less side effects. They certainly do work. So there's a role for them. But the idea that like, oh, it's 20 milligrams a day or 40 milligram extended release, I can do it forever, no consequences, that's just not simply supported by the data.
Okay. So let's start our rapid fire with this question, because you answered a lot of the questions I think people might ask about that type of therapeutic. So the question is, how do I avoid resistance in these lower dose regimens?
Yeah. From my standpoint, it's similar to what you might do for any antibiotic regimen. So using concomitant benzoyl peroxide to help reduce resistance of the skin flora, just like we do with topical antibiotics, that I think can be helpful. Having a good regimen or plan to try to get off antibiotics. So potentially starting something like spironolactone and knowing that's going to take longer and using an antibiotic to get through that initial period, but with the goal being to just be on spironolactone in the long term. Thinking about isotretinoin, I think when you look at patients who end up on there, they often get about a year of antibiotics first. And if you knew you were going to end up on Accutane, you'd probably rather just do it at the beginning because it's disease modifying.
Right.
So
exactly.
Trying to identify patients who are going to end up on isotretinoin anyway and think about that maybe earlier. Again, there's challenges and risks to isotretinoin. We could talk about that. It's not for everyone. It's a medicine we need to be thoughtful about. But if we're going to end up there anyway, maybe we need to do it earlier.
Got it.
So things like that, just like really any antibiotic, I view it the same way as any other antibiotic regimen.
Great. So a good segue into the next question, isotretinoin, which we know is applicable to both acne and rosacea in some cases. Isotretinoin, how many times can I repeat that regimen on a patient?
And so for rosacea, it's a little different than acne because it's not disease modifying. You treat people with rosacea, they tend to relapse afterwards, whereas acne, it's much less common. So that's one initial difference. I really don't think there's necessarily a maximum dose of it, and for a few reasons. One, patients absorb it differently. You can give someone 120 milligrams of isotretinoin, they're a 70 kilogram person, they get no dryness, they're clearly not absorbing it well, and that's where maybe those light dose formulations can help. You can give the same dose to someone, and they're like completely dry, like super side effects. So people absorb it differently, and the cumulative toxicity of it's going to depend on that. So I tend to think more clinically than dose when I'm thinking about that, and the same way about courses. So I don't necessarily be like, oh, 3 courses is too many, 2 is fine, or there's some X numbers too many. Too many is really when the side effects start to accumulate. So chronic dryness, if you treat people long enough or too long, they will start to get chronic dry eye or other problems. So when I see people starting to have those symptoms, that's for me a reason to err on the shorter side or think about other treatments. Issues like inflammatory joint pain, those are another thing where we might want to think about using less. Though often that does get better when people stop. It almost always goes away, but it might be a reason to use less. We know maybe it can cause some issues with tendons or joints with really long-term use, like for ichthyoses for like decades. I think very few acne patients would ever get that much isotretinoin, but that's what I think about more. Like, are they starting to develop side effects that we know are kind of long-term side effects of isotretinoin, rather than like, oh, they've been on 2 courses or 3 courses, because depending on how you absorb it, depending on how long that course was, that's going to be different. So I go more by clinical symptoms than by any amount. There's no number of courses that's too many. We treat ichthyosis patients for decades.
Okay, great. That's great. So another question, unrelated. Regardless of morphology, all acne patients should be on a retinoid. True or false?
I would say false. Okay. So first off, some patients can't tolerate a retinoid. No matter what you do, use a minimum strength one, use one that's in a lotion formulation or a formulation that may have better tolerability. They just can't tolerate it. There are going to be patients like that, and you can use other treatments for those patients. And when we look at retinoids, like how well they work, they're great for comedonal lesions. They do work for inflammatory lesions, but they're best at comedonal lesions. So someone who's got more inflammatory acne, that's where something like topical antibiotics, benzoyl peroxide might be a better place to start. Maybe you start with like a benzoyl peroxide clindamycin combination product rather than a retinoid if they have really mild acne. Maybe you use something like spironolactone. There are plenty of patients who can clear on just spironolactone or combined oral contraceptive monotherapy, so they don't necessarily need a retinoid. And some patients may want to avoid topicals. They may just know that they just can't keep up with the regimen or don't like it, don't want the photosensitivity or other side effects, and we can use those other options. We can use those systemic treatments or procedural treatments instead, and what matters is getting people to their goal. So I don't think everyone needs a retinoid. They're great treatments. We use them in many people, but they're not a prerequisite to get to clear.
Great, okay, fantastic. Then you mentioned, you sort of hinted towards cumulative dosing problems with isotretinoin. So how often is cumulative dosing a problem with, let's say, tetracyclines?
Yeah, so with oral antibiotics, I think a lot of guidelines would talk about trying to limit therapy of 3 to 6 months, and I don't necessarily agree with that. When you look, for instance, at changes to the microbiome, you can show they happen after 3 to 4 weeks. And so this idea that like at 2.9 months you're fine and at 3.1 months it's bad, I just don't think that makes sense. We really should be more thoughtful whether you use an antibiotic at all, because anytime you give someone to an antibiotic, you're going to disrupt their microbiome, you're going to put them at risk of antibiotic resistance, and certainly less is better. I wouldn't disagree with that, but it's not clear to me that 3 weeks is particularly different than 3 months or 3 years for that matter. So I focus more on the decision to use an antibiotic or not, thinking about ways to get off of it if we do use it, rather than like, oh, it's 3 months, let's stop it. Because you know what's going to happen? They're going to flare, they're going to come back in a month, you're going to put them back on it.
Right.
So I don't like to do that. I like to think more about, should we use this at all? And if we do, and it's the best treatment for someone, I don't get too stressed if they're on it for a long time.
So, okay, Dr. Barbieri, let's end off with just a couple of quick fire things that maybe you can just give us some quick answers on that might be curious things for our viewers.
Sounds great.
So we talked a lot about these things, but let's say number one, doxycycline, the most common side effect, or one of the common side effects, photosensitivity. So true or false, doxycycline is more photosensitizing than minocycline?
True, though I still don't use minocycline for acne patients due to the risk of drastic and severe side effects.
Okay, so minocycline is stronger anti-inflammatory than doxycycline?
I don't think false. I don't think there's evidence to support that. Maybe, but I don't think we know.
Got it. Spironolactone, I should never go above 100 milligrams per dose.
Totally false. The best dose is 100 to 150 milligrams a day.
Fantastic. Isotretinoin, it's 100% necessary to do labs every month on a patient.
False. When you look at the data, there's little evidence to support that lab testing is helpful, and actually the British Journal of Dermatology recently had a piece saying that no lab monitoring is required.
All right, great, fantastic. And lastly, antibiotics are problematic with birth control.
False.
Okay. And, if you want to expound on that a little bit, tell us why has it been in our vernacular, why was it in our guidelines for so long?
Yeah, the reason I say false is there were some concerns with rifampicin in the past, but the American College of Gynecologists has really put out a statement that for other antibiotics is not something we should be concerned about.
Okay, excellent. So, last question then, if you're going to put a woman of childbearing potential on long-term antibiotics, you need to periodically check pregnancy tests.
I would say false. It's a great question. The risk is really to bones and that kind of dental development, so in the first trimester it's maybe lower risk than some other things.
Great, fantastic. Well, that was awesome. Very useful and very practical information for all of us that are in our dermatology clinics day to day. So I'd like to thank you, Dr. Barbieri, for stopping in the studio and helping us out, and I'm looking forward to actually sitting through your lectures.
Thanks so much for having me.
All right, awesome. Thanks a lot for sticking around at Dermcast TV. This is Rob Casquejo.